Okay, we're good. Hi, I'm Joseph Wood-During, and today we have a special guest here. We have Lyle Murphy, the founder of the Alternative to Meds Center. And the reason I thought it would be interesting to have Lyle come on and talk with us is because I get asked a lot in my practice, is there anywhere I can go? I don't feel like outpatient level of care is really suiting me. I'm looking for something that's a little bit more intensive. And I almost never have any places to recommend to folks. And then so I found Lyle online, looking at different things, and I'd heard about his center. I thought it would be a great opportunity to bring him onto the show so he could talk a little bit about, I guess, the work that he's doing at the Alternative to Med Center. So I'm going to turn it over to Lyle, and I'll just have you introduce yourself, and then give us a little bit of information about why I guess, what the center is, and then why you started it.
Okay. All right. My name is Lyle Murphy. I'm the founder of the Alternative to Med Center. We are a state licensed higher level of care residential that's also JACO accredited that helps people reduce and or eliminate the need for psychiatric medication. A lot of what we do is not just careful medication tapering and supplements, but it's also unpoisoning people. Some of the fundamental principles of what we do surround a science called environmental medicine, which really deals with what type of poisons are out there in the environment, what type of genetic vulnerabilities are most susceptible to those toxins, and then the mechanisms to clean that stuff up and get a person better. And a lot of what we're being exposed to through pesticides or mercury or whatever really are neurotoxic. They destroy the body's ability to regulate its neurochemistry. And some of those some of those patients are really easy to see once you know what you're looking for to tell if a person's toxic, and be able to, help those people in a way that just medication tapering alone would be not able to do.
Mm-hmm. And so Lyle, how did you get involved in doing this kind of work?
Well, I was going to school to be a chiropractor. I had actually foregone going to Emory. I had the pre-med grades and the letter of recommendation, everything to go to Emory. And I read a Harvard study somewhere that said that the top 20 drugs prescribed for the top 20 disease processes actually performed worse than placebos. And I couldn't imagine myself prescribing at that point. Now, I wish it would have dawned on me at that time that having a medical license would have allowed me to unprescribe those very same things, but that really I wasn't that far-sighted at that particular time. So I went into a drug-free profession of chiropractic and got all the way up to the end of my education, and literally as a starving student I went into hypoglycemic shock from not eating and ended up in a coma for 2 weeks. When I came out of the coma, I had an IQ of about 4. I couldn't talk. I couldn't walk or balance. I couldn't remember most of anything. And I certainly wasn't going to be anybody's doctor in that particular, like that. And it took me 10 years to recover. I was actually volunteering at a drug rehab that had a sauna program. And they allowed me to do the sauna program. And it literally brought me back from 10 years of being in a brain fog. And I didn't completely identify with all the tenets of that rehab process. It was a little bit too fundamentalized for me, and I'm very nonconformist in many ways. So I went back to school, and got a postdoctorate in environmental medicine, and really learned kind of the ins and outs of how to unpoison people, figuring that, there's other people out there that are ending up in a psych ward because they have blood sugar problems or have poisons that are affecting their neurochemistry. And by and large, that is the majority of people. Very few people have organic problems that are leading them into a psychiatrist's chair. They usually have things that are remediable that can be alleviated without or with minimal use of psychiatric medication.
Mm-hmm. And I mean, just curiously, the low glucose thing that happened, did they ever find out what caused that? Was it purely, poor intake, or was there some other medical process going on that, you got so sick you were in a coma, that's...
Yeah, I mean, I just wasn't eating. and I
Yeah.
was eating like a student. So I was
Yeah.
eating, whatever cornflakes or, just didn't have much attention on my diet for being a chiropractor.
Sure. Okay. And so I think I was reading, I think on your website now, correct me if I was wrong. Were you prescribed psychiatric medications at any point during your recovery or while you were trying to heal from all of this?
Oh yeah, for that 10 years afterwards, I really
Hmm.
did resemble the diagnosis schizoaffective.
Hmm.
I didn't have that many really super high functioning, brilliant moments like most schizoaffectives do because I was really post, basically stroke like residuals. But I was having the very lofty, believing that the spiritual unfolding of the planet was happening through my brainstem, that I was being followed around by people with cameras, and that I was on a reality TV show. And so when that would happen, I would get thrown into a psych ward somewhere, tied down, force injected, drooling on myself, kind of stuff. So yeah, but the fortunate thing for me was I was so handicapped, I was so disabled that I couldn't even keep up with like taking the medication and going to see doctors.
Hmm.
So I didn't stay on these meds very long. It was more like acute care stuff, getting me whatever their version of stabilized was, and then turning me back out to, flounder and be low functioning again.
Okay. And so I guess so it sounds like when you were recovering from this coma, you were having some psychotic symptoms. People were saying that you had schizoaffective, you were hospitalized, you were on medications, and you kind of went through this pattern for like 10 years or something before you healed yourself through this program. Is that right?
Right, correct.
Yeah. Yeah.
And it was
What?
like a
Yeah.
light bulb. I mean,
Hmm.
I had what felt like a football helmet on my head. I literally couldn't see above my eyebrows. It was all fuzzy up there. And I felt like there's this weight on my head. And I mean, I was sleeping 18 to 20 hours a day. And even when I wasn't sleeping, I wasn't really awake. And it just one day it just was gone. It was quite unusual. When you've
What
been
do you?
impaired with
Mhm.
neurological symptoms for a decade, you don't usually see that just vanish. It hits sort of a plateau and you're kind of stuck there for life. And that's where I thought I had gotten to, was that plateau. And all of a sudden, it was like miraculously, like magic wand kind of healed. And yeah.
Okay. And so I'm guessing you're somewhere in your 30s, right? When you kind of wake up from this decade of disability, right?
Correct.
Yeah.
Age 25 to age 34.
Okay. And what do you think it was about the sauna program that healed you? What, like looking back on it now with your knowledge of treating patients and environmental medicine and such, how do you understand that recovery?
Usually people get incrementally better. Um, I haven't seen too many people just have like a pop from being so disabled that they can't even take care of themselves hardly, to like going back to being somebody's doctor.
Hmm.
That was unusual. I don't really have a mechanism for that. I know that my brain seems to have a higher requirement for vitamin C than what my diet would normally produce, and I'm sure that's part of it. But I don't know. That part remains a little bit of a mystery, honestly.
Were you doing dietary changes at the same time you were kind of going through this sauna program? Was it multiple things happening, or was it really like the sauna program that kind of kicked things off, and then the rest kind of followed shortly thereafter with your improved, I imagine, motivation and to continue to heal yourself?
All the organic diet and more focused supplementation came after that. It really was just this process. And um, so by and large, poisons that will accumulate in your body are going to be fat soluble. And they can bind to, any cell in your body, any cell membrane, it can affect your nervous system. To get those out, you need to transform them into a water soluble form. And that's what that particular process I went through is a biotransformation process, phase 1, phase 2, bioactivation and conjugation of poisons. Well, that was a very antiquated approach, and there's much more, current and um, uh, more, top shelf science approaches on how to really focus that in there. That program did really nothing for metals. We put a lot of attention on heavy metals. These things can really do a lot of havoc, specifically neurochemical havoc as well. So, yeah.
Interesting. Okay. And so tell me a little bit about I guess the start of the Alternatives to Med Center. Did this start off as like an outpatient practice doing some consulting, or did it start as a residential? What was the beginning of this program like for you?
Well, I had access to some single room occupancy places in San Francisco. Not necessarily the best place to have people, wind down and be in a spiritual experience. It's very loud in San Francisco, but one thing that was advantageous is I could work with schizophrenics, and they could be on the streets of San Francisco and go relatively unnoticed. So in the beginning, I was working with schizophrenics and seeing if some of the orthomolecular principles that were talked about by Linus Pauling and Hoffer and Richard Cunyon and Michael Lesser and some of those folks actually played out in real time. And I found a very distinct difference in the populations. Like what a lot of people were defining as schizophrenia, I wouldn't have defined as schizophrenia. It kind of came down to, if a person is experiencing symptoms all of the time, they're having loose associations or hearing voices, and they've been low functioning for a decade, that's much different than a person who has intermittent psychosis that's high functioning mixed with complete train wreck, the more effective population. The modalities, the vitamin, the high dose niacin, the high dose vitamin C, worked really good on the schizoaffective patient, but it didn't necessarily like pop somebody that had an organic brain damage or had been low functioning schizophrenic straight out of it and put them back into college where they could be high functioning. So I just came to realize that if it works some of the time, it's not broken. And it's really just a matter of figuring out what is causing the person to go into to being symptomatic. What is the switch there that's getting flipped? And for most people, it was marijuana. And marijuana has different effect on different people. And it's a fat soluble compound. If you test an employee for marijuana, they can test dirty for up to 30 days and with normal physiology. So a person that's got impaired physiology that can't make that leap from transforming a fat soluble, cannabinoid into a water soluble form where it can be expelled from the body, it amplifies its concentration faster than the person. If a person's still smoking it, their bioconcentration of that goes up faster than their elimination does, and so they end up at psychogenic levels, and lo and behold, they're looking like they're schizophrenic when it's really just a drug-induced psychosis. There's other reasons. I mean, in my case, it was blood sugar. Some people's case, it might be food allergies, but it's just really just a Columbo sort of investigative Sherlock Holmes process to figure out what is this person doing that's not in alignment with their, how their particular individual physiology works, that's causing them to be symptomatic. And once you figure that out, and the person can, adhere to it in a relatively angelic sense, they're not a product of psychiatry anymore. They're functioning and playing their cards the way that their cards need to be played.
I think I'm gonna jump in here and ask you a little bit more. So you've got this experience in environmental medicine about, I guess things like lead, other toxins, pesticides. It also sounds like you are up to date with orthomolecular medicine and the different, I guess, what many people might say, functional medicine these days. But what else do you offer at the center? I mean, what are the other pillars of your treatment approach outside of those two areas?
Well, we have a full naturopathic team.
Mm-hmm.
We have psychiatric prescribers that are, definitely friendly to helping people reduce or eliminate their medications. And then we have, we have counselors that do trauma work, that do, cognitive things to help people integrate. People that have been snowed over by these medications. The one of the things that I don't know if jealous is the right word, but when you're working in the conventional paradigm, when you dope somebody up high enough on medications, you don't have to deal with their emotions. You don't really have to help them integrate much of anything, if anything. When you're pulling people off of medications, all of those layers start to become like when you're snowed over on Zyprexa, you don't care what sex you are, what sex you're attracted to, what religion you adhere to, what your purpose is in life. All of that's really super muted. But when you start pulling people off those, the antipsychotic medications, all of that stuff starts to become relevant, and it can become relevant really fast to the point of perseverating over it. And the balance is to just reduce those medications at a rate where they can integrate those new feelings and have them gel into some kind of understandings or how to move in the world. It's very nuanced work. There's no it's not a matter of just prescribing somebody something and sending them home. You have to help with these feelings and things that come up in the time that they come up. Otherwise, the person's going to stall out or even spin out.
Yeah, I think that's a really interesting point because, if I think about the traditional inpatient psychiatric setting, it's one physician, maybe there's like 20 patients there. You get a 30-minute intake, and then they might see the patient for 5 minutes a day. They're not conducting the kind of history which I imagine you are, where it's more comprehensive. You're talking about trauma, things that are going on, things that led to them being on the medications, and I guess doing a more comprehensive dietary and even exposure kind of history. It's like, okay, you have these symptoms, you fit the criteria for schizoaffective, and now we're just going to go and, okay, you didn't respond to Zyprexa, we'll put you on some Risperdal and some Depakote. Visit done. And then maybe they look at the labs or something like that, but they're not set up. They're essentially they're not doing the same work. It's very it's almost like a production line kind of thing in some settings, which is it really is a disservice to patients that are having more of these complicated problems. Like you said, they don't all present the same way. If you have someone with intermittent psychosis who is high functioning and they're just not fitting the clinical course of schizophrenia clearly, I mean that may be a sign to look deeper at some of the things that you've been describing.
Well, and another thing that's just kind of boneheaded. I mean, we tend to believe that doctors are gods, and I'm not a god. You're not a god. We know that, but sometimes patients view as that. And what is really a disservice to the mental health population is that the people that have the most limited amount of exposure to the patient, being the doctors, are the ones making the biggest decisions for that patient's life. And that's why a residential center, I think, works much better. I can't figure out people outpatient. I do very little outpatient work because there's just so many variables. When I have somebody inpatient, you have somebody around them 24 hours a day that can tell what's working, what's not, in more of a real time, and give feedback to the prescribers and say, hey, they're not doing that well with this particular medication cut, or this bridge medication that you're using is working great, or whatever. But in a doctor's office, you don't get that, especially even if you get to a doctor's office nowadays. A lot of it's telemedicine, and it's just It's
I mean,
like a form of, it's like gambling.
it's broken. You know, I think the system is broken for a lot of people, and I mean, unless you have a lot of financial resources and you can go somewhere private and you can get in pretty quickly and find someone who can do a good job, you end up, with 15-minute appointments 3 months apart, with very little nuance in the prescribing decisions.
Mhm.
So coming back to, I guess, the start of your clinic, I'd love to hear about that. Uh, how did it start? The residential center. Tell us about the first couple of years of launching that project.
Well, it was trial and error.
Hmm.
I mean, the first 4 years, honestly, were nobody. I mean, there was at the. I mean, we're going back almost 20 years now.
Okay,
So I don't know, how long have you been in practice?
7 years.
Okay, so this is way before anybody was really talking about
Hmm.
medication withdrawal. If you talked about medication withdrawal back then, it was like if you talked about something besides um the John Wayne sort of propagandized machismo male version back in the 50s, you must be a communist to not
Hmm.
buy into that. And you're labeled a communist and you're thrown out of Hollywood. If you were talking about, psychiatry might have some gaps back then, you were called a Scientologist. And so you
Hmm.
got lumped
Oh,
into being a Scientologist. Even
yeah.
I remember even our because we would hire, standard psychiatrists to help us withdraw people off meds and give them some guidance, like, oh, we think they should go from 5 milligrams of Zyprexa to 3.75. And I remember seeing all this stuff online, like, oh, your psychiatrist is a Scientologist. And I'm just like, oh my God. So back then you had Scientologists, you had a few rogue sort of lone wolf orthomolecular people, and then you had a batch of psychologists that were doing work with people around just psychological interventions rather than using medications. That was it. And if you went looking around for information that might be working, there wasn't much there. So we put a lot of this stuff to the mat to see, what might work and might not, to the test of truth. And some of the orthomolecular stuff panned out, and some of it didn't. And it wasn't really until we started unpoisoning people. I mean, with my first batch of schizophrenics, I probably had about a 25% success rate getting people off medications, having them stay off medications, and going to be high functioning. That's what the orthomolecular interventions alone were doing for us. Once we started unpoisoning people, we really started targeting organic and metal poisons and getting them out of people's body. That's when our success rate shot up to around 75%. And then we added the spiritual layers, the psychological layers, the family, intervention layers, and good aftercare programs for people to be successful out there in the world, that we started hitting, 80% and above.
And when you kicked this off, was this I guess a one-man show, or did you have collaborators who launched this thing? Because you look at the center now. I mean, you have a lot of staff members. You're doing so many different things. Uh, what was it like? I guess starting it. Was it just you? Were there other people? I guess
No, it
Are
was
you in Sedona? Is that right? Or
yeah, yeah, it's
yeah,
a beautiful place to be.
yeah.
We found a great home to do this.
Hmm.
It's very tranquil here. People don't need a gym. They don't need. I mean, you just go outside. Outside is a gym. But um, no, I was pretty much that lone wolf kind of manifesto person that you think of, like being in a like a 8x8 room, like with a bare light bulb hanging from the ceiling, like tapping out this manifesto on a typewriter with a couple of broken keys. I mean, I really didn't get much respect,
Hmm.
and it was really hard for me to swing doctors into like entertaining withdrawing people off medication. And I remember getting 2 employees, and I almost felt like the table was like kind of floating. I'm like, whoa, this is great. I have some help. And then then I had a nurse come on that was like, this guy is right. This guy is absolutely on point. And she helped swing in, some doctors and some other professionals. And now the culture's changed. I mean, I used to get people call me 20 years ago and argue with me about why they should stay on medications. I'm like, well, why are you calling me then?
Yeah.
And now I get, people that have already read up, that have watched the videos, sometimes, big name celebrities that I would never have met if I wasn't doing this kind of thing. And they're like, okay, how do I send my loved one to treatment? They already understand that psychiatry is very limited in its ability to be able to help people. And it did not used to be like that. It was like cutting across the grain when the grain was like made out of titanium back then. And now it's like, it's got some lubricant.
Hmm. Yeah, I mean, more than that. I mean, I look on your website. It seems like there's like a spa associated with the facility where people can go for treatments, and then you have the residential facility. I mean, it really looks quite impressive what you've built. A very comprehensive, healing place. It looks great. Um,
It's probably the most complicated rehab in the country.
yeah, yeah. Tell us more about what it looks like if someone comes. Let's go with someone who maybe they've got depression. It's not working out for them. They're on an antidepressant, an antipsychotic, maybe something for sleep as well. What does a program look for someone like this that comes to see you if they were going to get the whole 9 yards?
Um, well, generally we try to push people into the, unpoisoning track. The depressed and anxious population, they have, there's a lot of reasons for depression. There's a lot of reasons for anxiety. Again, one of the big differentials is it constant or is it intermittent? When you get that patient, which is the patient nobody wants to get, no rehab wants the patient that the more you reduce their benzos, the more anxious they get and they don't come out of it. And they go into protracted withdrawal and they're not sleeping and they're not eating and they can't even hardly drink water. I mean, those are not your detox facility type patients. There's some patients that they're on 8 milligrams of Xanax and they're just kind of addicted to it, and you can withdraw them off of it and at a conventional center and they're okay. We don't generally see those type of patients. We see the ones that as they try to reduce the medication, they get to a place where they're stuck. And I guess one way to try to introduce this is there's what a neurotoxin does is it poisons the way that the neurochemistry works. Like, for instance, a pesticide. A pesticide knocks out a pest by disabling its nervous system.
Mm-hmm.
So organophosphates or organocarbamates, which are popular pesticides. If you can imagine a grasshopper uses acetylcholine to kick its leg. So acetylcholine is released, the leg kicks, and then the sodium channels close, and the leg stops kicking. Well, if you put a pesticide in there, it poisons the enzyme that actually the acetylcholine esterase that will pull acetylcholine back off of the receptor site. So acetylcholine stays stuck there, and you get a constant inflow of sodium ions. The grasshopper goes into tetany and dies. And you see patients come in that look just like that. They're not able to regulate their nervous system, and it's a constant disposition. So they're like, how are you going to get me off my meds? Every time I try to get off my meds, I stop sleeping, I stop eating, and go into crisis. Well, that's like if your nervous system was a game of catch between you and your son or something, and you're just kind of lobbing the ball back and forth to each other. That's the vesicles throwing the neurotransmitter over, hitting the receptor throws it back, so it's reuptaken, and it's a normal exchange. You put a neurotoxin and it's like putting a major league baseball player up to the end. Looks like we've paused a little bit here.
Yeah, I was going to say I lost you just for a moment. the last thing I heard was it's like playing catch with your
All right,
son. I was wondering if you could repeat your analogy.
pause here.
Yeah.
So okay, so a neurochemical back and forth. The synaptic vesicles hold, a neurotransmitter. They throw it over to the receptor. It does its thing, and then it comes back and gets reuptaken. That's like a normal game of catch, right? But when you've introduced a neurotoxin, it might be like having a Major League Baseball pitcher throw a 100-mile-an-hour fastball at your bare hand. You're not going to catch that very long without using a glove. So then the person starts introducing Xanax or some other type of benzo to kind of soften that pitch, right? Then they try to thin the glove down. They thin it and they thin it. And they get it to the place where it starts hurting again. And they can't get any farther. And that's because they're neurotoxic. So part of what we're doing is we're unpoisoning the nervous system from the metals and from the other excitotoxic things that can dysregulate a person's neurotransmitters. And our nervous system, our brain is a biochemical organ. It's very, very susceptible to chemical change. A very small amount of chemical change can produce a lot of neurochemical havoc. And when you see patients that can't regulate, they have constant symptoms of OC, usually neurotoxic, and you have to unpoison them before they're going to be able to find relief. So it really is that part of the differential diagnosis. If they're coming in like that and their first agenda is to get off of meds, I mean, if they're over medicated, yeah, but usually people have shaved it down to the very bare minimum and want us to just finish off that last 1/4 milligram of Klonopin or something. And it doesn't really work like that, because now you've just got a bare hand with a fastball pitcher, right? You've got to unpoison that person enough to where the nervous system is actually doing a normal interchange, and then getting off the Lexapro for 15 years. They've got a bad diet where they're just basically eating sugar to try to artificially boost their serotonin levels. Then reducing those people off the medications, upping their serotonin levels using tryptophan, and getting them on an organic diet can just sort of sweep them right out of it. So it really depends on your patient. And it's very, very specific. Sometimes people have Lyme disease. Some people have damage from vaccinations, which is a whole nother malady that we seem to be facing right now that is confounding us and other practitioners too. But yeah, the prognosis really depends on what the presentation is.
Okay, good. And well, I know you were talking about helping people stop that final bit of benzodiazepine, whether it's Xanax or Klonopin. That's most of what I do, and I would say, another way to, I guess, at least the way that I've been thinking about it, as well, is that these medications are actually damaging to neuronal tissue, because I'll have some people and they've completely come off the medication, but they'll have symptoms that linger for years. And it's really hard for me to kind of explain, why they're so debilitated, aside from, you're on this Xanax and it's just triggered some, usually the neurological symptoms start when they're tapered too rapidly. So they're fine. They're on their Xanax. It's working. They go through a rapid taper, and then everything just falls apart. You've probably seen it, the ear ringing, the electrical pain, the shooting pain, the fear and the anxiety. And we'll bring them down slowly, and they'll still have all of these symptoms, but it's like, okay, your brain will recover, you will get there, we'll finish the taper. And then they're still having symptoms for, several years after that, but then they tend to recover. It's like this healing process there. So it's, I can't imagine how complicated it's been for you to manage those patients as well, because it's a handful over here trying to help them, because they're in so much pain and they don't eat as well. Really tricky stuff.
I do think that there's something generally being missed there. These patients got put on these medications for a reason. They were having some sort of symptoms, and then they'll blame it on the medications. Well, the medications are what made me so messed up, and if I can just get off these medications, I'll be fine. Not that the medications didn't do their damage and mutate receptors and cause, downregulation and all the stuff we know that happens with these type of meds. But did they ever really deal with the reason why they got put on these meds in the first place? If that reason is because they're neurotoxic, that's a lot of the reasons why they're suffering for years and years and years.
For sure.
One of the things that we're throwing a lot of money at research, a lot of money with our EMR capturing all these data points with diagnosis and symptomatology and what sort of interventions we took. One of them that is a real hot spot is mercury.
Mm-hmm.
If you look in a lot of these people that have that chronic symptomatology, they're suffering for years, they're going to suffer no matter what drug they get off of. If they've got a mercury burden, that specifically seems to poison their serotonin pathway. And when your serotonin pathway is poisoned, you have constant fight or flight type ruminations, you have constant sleep problems, and you ruminate, obsessively over things. And the only thing I've ever found that's healed that is getting that mercury out, getting the mercury out of their teeth and actually doing a chelation process that'll help alleviate that mercury. And we've seen it over and over and over and over and over and over again. It's kind of like if you own a Prius or something. To anyone else, that might just be a little car, But once you get used to seeing Priuses, you're like, oh, there's another Prius. There's another Prius. When you get used to seeing your mercury toxic person, it's like, there it is, people start telling me their story, like, of what their symptoms are. And I'm like, oh, by the way, do you have any mercury fillings? They're like, yeah, how do you know that? I'm like, well, because this is how a mercury toxic person presents. It's just exactly like what you're presenting as.
Mm-hmm. Mm-hmm. Yeah. So my impression from looking at your website is you treat everyone. I mean, a lot of these, it looks like you're familiar with schizophrenia, bipolar, anxiety, depression, withdrawal. Would you say the clinic has a specialty, or is it kind of, able to kind of help people from all walks?
Well, my particular specialty is I'm a bit of the psychosis whisperer.
Yep.
I work particularly with people who are coming off antipsychotics. And in some ways it's really difficult, but in some ways it's a little bit more limited. If somebody's having intermittent symptoms of psychosis, there's reasons for that. And as long as they'll avoid those certain things and introduce certain supplements and diet and avoid, caffeine and avoid smoking pot, they can kind of move through it. I don't think many people, especially practitioners, feel that when you're reducing someone's antipsychotic, when they start to become symptomatic, that it's a withdrawal. They look at that as, oh, there's your diagnosis coming back again, and see, you need this medication in order to be stable. Those medications, by holding back dopamine is like a reward neurochemical. It also keeps your spine, erect. It keeps your head somewhat level to the horizon. These are very important functions, right? When you knock that out, when you knock out the availability of dopamine, your body just builds more receptors so that the little bit of dopamine that's coming through has a higher chance of exciting something. So you've got all these dopamine receptors sort of starving, and you take back that medication and you start giving a near normal amount of dopamine to these excessively volatile receptors. Everything becomes exciting. Suddenly they're not sleeping. They want to know what God's thinking. And if you do it slow enough, some of that stuff can get integrated in a way where, they move through it and life becomes boring again. You do it too fast, it's like stepping off of a 10-story building without taking the stairs. You're going to get hurt. And so I specialize personally in that type of withdrawal. I do most of the coaching for people that are going through that. But yeah, we do help people with the opiates, the benzos, the antidepressants. The line kind of gets drawn with, maybe serious Lyme patients or serious autoimmune type things. Not that we can't help stabilize those things, but some of those patients are really difficult. And it takes a lot longer to move them through it. It's not an 8-week process. And unless those people have a lot of resources, we tend to discourage them from mortgaging their house on something that's going to take a lot longer to peel through than an 8 or 12-week process.
Mm-hmm. Okay. I'd like to ask you about your experience doing some antipsychotic tapers, because we've started doing some of these as well. Usually patients coming to us because they've gained a whole lot of weight, and they're trying to come off, and some of them have, I would say something that appears to be pretty chronic and legitimate psychosis, and the outpatient management has been really tricky, because although they're doing better on much less medication, they'll periodically have these flare-ups of psychosis, and their family will get worried. And then there's like, what do we do? Do we, bring them to a psychiatric hospital and, they'll get loaded up on something, or do we go back to the other medication? So I just want to get your perspective. Like, how do you manage these patients that may have some residual psychosis, I guess, after you've kind of weaned them off medications and they're doing better? Yeah.
I think the really rub there is what residual psychosis means. So I've had now two of the biggest axioms about coming off antipsychotics: you cannot drink caffeine. It is a big no-no. Even 1 cup of caffeine at the wrong moment in an antipsychotic withdrawal can send someone to the hospital, because you're flooding even more dopamine in there. So people on antipsychotics were usually drinking copious amounts of caffeine to try to self-medicate how tranquilized they are. They're going to have more than residual psychosis. They're going to have very active psychosis during the withdrawal. And then marijuana is the other thing. If they're marijuana and they're smoking marijuana during the process, they're again going to be psychotic again. A third thing is it may not be enough to be the sole culprit of a person's rebound psychosis, but a blood sugar swing can certainly amplify any other sort of hypomania that's happening. So putting people on a diet where they're getting up, they're eating in the morning, a substantial breakfast, to get their blood sugar at least leveled out for the day, preferably eating small meals 6 times a day to balance out their blood sugar, is another important thing. The three things that help break down dopamine: vitamin C, oxygen, and lithium. So oxygen can be, you put them on a treadmill for 20 minutes, or if they're symptomatic, you get them to go run, whatever. And it doesn't take bipolar that is basically prescribed at neurotoxic levels. We found it doesn't have to be prescribed nearly at those levels. If a person's not already on lithium, we'll put them on lithium orotate, maybe 40 milligrams of lithium orotate, to help metabolize the extra dopamine that's coming up. And sometimes that's enough. But let's say somebody is that schizoaffective type, they've been on Zyprexa or some form of antipsychotic for 4 years, and they're trying to come off of it, and you're doing it outpatient. It's probably going to be at least a 6-month program, right? When they come from 10 milligrams, then maybe they go down to 8.75, and they hang out there for 3 weeks or more, and then they come down another 1.75. When they get down to maybe 5 milligrams, that's a good time to implement a bridge medication. One of the better bridge medications we've seen is Depakote. Now, it depends on if you're a female that was expecting maybe to become pregnant, but for most people, if you bridge in about 1,000 to 1,500 milligrams of Depakote, right about that last 50 or 25%, and then ease them off of the antipsychotic completely, and then bring them back off the Depakote, you're working on 2 different pathways. When you're reducing the antipsychotic, basically that's a little bit of pressure for you. Just enough.
Hang on one second, Lyle. I just lost you for about 10 seconds. The last thing I heard you were talking about bringing in Depakote at that last, I guess, I don't know, 5 milligrams of Zyprexa. Could you go over that again? I just want to make sure we catch that.
So when you're coming off an antipsychotic, you're giving more availability to an excitatory neurochemical, the whole catecholamine pathway, specifically dopamine. So if you're imagining you've got a 18-wheeler truck that you're trying to get down a mountain that has switchbacks and it's kind of icy, you're basically stepping on the accelerator. Even if you're doing it slowly, you're stepping on the accelerator to a certain degree. All right. Now at the upper levels, if a person wasn't symptomatic at 10 milligrams, they might be able to endure a little acceleration and get through it, get around the corner, and then get down to 7.5 and get around the corner. But as you start to get lower, obviously towards the end, that's when things become a little bit more, a little bit more touchy. So to soften the amount of acceleration that you're having on a different pathway, Depakote is it's like a GABA enhancer. It enhances the effectiveness of GABA. So you're stepping on the brake just a little bit to make sure that acceleration that you're experiencing coming off of the antipsychotic has a little bit of counterbalance, and that might be just enough to get them over some humps. Now, again, they can't be smoking pot. They cannot be doing
caffeine.
Caffeine, especially during the latter part of the withdrawal. I've got story days. Well, not completely derailed them, but derailed them for the moment.
And
so that has to be perfectly clear. If I'm working with an outpatient person, of course at the center they're not going to have any access to pot or caffeine, but if I'm working with an outpatient person, they can't completely commit to that. I don't want to work with them because I don't want to be part of their catastrophe.
Yeah. Okay. Makes sense. So we're getting to time in about 5 minutes. I was hoping, with the remaining time, you could tell us about, how many beds do you have? What's the wait list like to get in, or do you usually have a little bit of availability? Tell us about, tell us a little bit about that.
It's an 18.
Oh no,
there
Lyle,
is a bit of
I lost you. I lost you again for a second. So I heard 18 beds. Yeah.
Okay, so we have 18 beds. We do generally have availability within a couple weeks of somebody applying. Yeah, and so a person fills out a pre-intake questionnaire that might take up. It includes everything from what bugs you've been on, how long have you been on them, what type of symptoms are you having, have you had any violent episodes, yada, yada, yada. Any sort of behavioral concerns, you have mercury fillings, what's your diet been like, medical records. I mean, it's a bit exhaustive to try to gauge whether the person's a good candidate for the program. And, a good candidate has the financial resources where it's not going to completely debilitate them to come to treatment. They have the time and they have an extraordinary willingness. This is not a passive program. It's quite active. There's, quite a bit of doing.
Yeah. And
so,
and how much does the program cost roughly if they do, I guess, just your normal program or the most popular program?
A cash pay program for 60 days is $65,000, which for 24-hour licensed care is pretty much close to the cost of what it costs to deliver that type of program. If a person has insurance, the insurance might cover a quarter of that. It might cover 3/4 of it. It really depends on the person's insurance.
Well, I think we're about time. I'm gonna turn the recording off in a moment and then ask you a couple more questions before we wrap.
Okay.
So Lyle, thank you so much for coming on and sharing about your clinic. It was a pleasure to have you here.
Thank you. Thank you. I appreciate it. And I hope
Yeah.
that more seeds like you get grown out there to, help Pied Piper these misfit toys in a completely different direction.
Yep. Okay. All right. So let's